Good evening. This is Jasmine Wheaton, and this is my presentation on enuresis, also known as bedwetting. So here on this slide, we have a YouTube video that discusses what enuresis is, some key contributing factors to what causes enuresis, and also some treatment options that are available to help children who are struggling with this. And so we are going to head over to YouTube to watch the video now.
Enuresis is intermittent nighttime incontinence in a child who is aged 5 or older. There are two types of enuresis, primary and secondary. Primary nocturnal enuresis is by far the most common type. It is urination at night, during sleep, in a child aged 5 or older who has not yet attained bladder control. It is often due to a delay in maturation of bladder control or due to a developmental disorder. This type is more common in boys, and it usually resolves on its own. Because most cases resolve spontaneously, the treatment for primary nocturnal enuresis should not be considered until the child is 7 years of age. Secondary nocturnal enuresis is involuntary passage of urine in children who have previously achieved bladder control. This secondary loss of bladder control can be due to an underlying organic disease process, such as a urinary tract infection or diabetes, or it can be because of psychological stressors, such as birth of a sibling, school problems, and family discord. Diurnal incontinence, loss of bladder control during waking hours, is often associated with enuresis, and nearly 80% of these children lose control at night. Treatment of enuresis depends on the type and etiology. For most cases, reassurance is enough, as some children will outgrow the problem. Sometimes, behavioral modifications, enuresis alarms, or medications can be used. If incontinence is secondary to another pathology, treating the underlying cause will resolve symptoms.
So that brings us to the end of our YouTube video. And now we will head back over to our presentation to discuss background information on enuresis. So the earliest accounts of enuresis dates back to 1550 BC. Its discovery was credited to an Iranian physician by the name of Muhammad ibn Zakaria al-Raziz, also known as Rhazes. It is believed that he discussed this disorder within one of his books entitled The Herbis Papyri, which was also written in 1550 BC. From there, in 1790, its name was changed to nocturnal enuresis, which essentially translates into urinating within that happens at night. This is congruent with what was discussed in the YouTube video. Though nocturnal enuresis is the main diagnosis for children and some adolescents, as mentioned in the YouTube video, it is another form of enuresis called diurnal enuresis, which occurs during the child's waking hours, which essentially can be the child being in school, playing, and things of that nature. So the description and the prevalence of the diagnosis. Nocturnal enuresis is described as one's inability to control their bladder, especially at night. As I stated previously and as stated in the YouTube video, though it is the most common form of enuresis, it is possible for a child to also have diurnal enuresis, again, which means that they are unable to control their bladder during their waking hours or during the day. The diagnosis is not very common. For children of ages 6 months to 5 years, it only occurs between 5 to 10%. and then it decreases as the children gets older. From ages 5 to 10 years, it drops down to 3 to 5, and then for children ages 10 plus, it drops down to 1%. So some diagnostic criteria. This criteria was taken directly from the DSM-5, and we will discuss each bullet point in slight detail. So according to the DSM-5, in order for a diagnosis of enuresis to occur, the following must be present: repeated voiding of urine into bed or clothing, whether involuntarily or intentional. Second, the behavior is clinically significant, as manifested by either a frequency of at least twice a week for 3 months, or the presence of a clinically significant distress or impairment in social, academic, or other important areas of functioning. And this was also mentioned in the YouTube video. So things such as being bullied at school, being in a home where there is some form of domestic violence, whether it's just arguing or whether it is physical, the parents giving birth to a younger sibling, things as small as moving can upset the child's balance, thus causing enuresis to occur. Third, chronological age is at least 5 years or equivalent development level. Fourth, the behavior is not attributable to the physiological effects of a substance. Examples: diuretic, antipsychotic medication, or any other medical condition, which is diabetes, could be spina bifida, it could be something like epilepsy or anything dealing with seizures. It should also be noted that a diagnosis could be given for nocturnal enuresis only, diurnal enuresis only, or they can be diagnosed with both nocturnal and diurnal. So some multicultural considerations. Enuresis is most commonly diagnosed in boys rather than girls. There are risk factors such as being younger in age, being Black or African American. Having a personal or family history of enuresis also increases the chances of a positive diagnosis. As I stated in the previous slide, other factors can contribute to the child's daytime habits, which can include an overindulgence in drinking of liquids. It could also include not feeling comfortable enough to go to the washroom. It could include some frequency things such as how frequently the child goes to the washroom during the day. It could also include those social aspects such as having a younger sibling, being introduced into the home, moving, bullying at school, anything of that happens during the child's waking hours or woke hours can attribute to their diagnosis of enuresis. If the child has a UTI or a history of having UTIs, this could also increase the child's chances of having enuresis. The child's bowel movements and frequency. This one just points to the fact that if the child is slightly constipated, it can cause the child to have some form of enuresis because of the pressure that is applied, and the child is unable to control their bladder due to the pressure. We also see enuresis being diagnosed with children who have developmental and behavioral issues, and also some psychosocial concerns. Interventions and treatments. Research shows that the following evidence-based approaches are the most commonly efficient to helping children acquire dryness. Dry bed training seemed to be the most common factor, as mentioned in the YouTube video. So things such as an enuresis alarm, which is an alarm that the child puts into the bed under their sheets, and if the child begins to urinate in the bed, the bell on the alarm will sound, thus waking the child up and encouraging them to go to the washroom. It will also help the child to learn how to recognize when they are using the washroom at night. And instead of them urinating in the bed, it will train their brains to wake them up so that they can go and urinate in the washroom instead of the bed. The next part of dry bed training can also include things such as a waking routine, which could be something as simple as every hour or maybe an hour and 30 minutes, the parent sets an alarm to wake the child up and encourage the child to go to the washroom. Positive practices, which is just like what was mentioned in the YouTube video, where you constantly reassure the child and encourage the child that it is okay and that they are capable to have a dry bed. They are able to get up and go to the washroom at night instead of in the bed. We also see things such as rewards like star charts, which reinforces the child to go to the washroom at night. So basically what one would do is create a chart for the month or maybe even for the week to set some short-term goals. And each night that the child is dry, you place a sticker on the chart, and if the child completes that entire week per se, they receive a prize at the end. Also bladder training. So training the child learning how to train their bladder. So once the child begins to feel the urges of urination, instead of them holding it, which creates that incontinence, they will essentially go to the washroom and release their bladder so that their brain and their bladder can connect, and that they're able to understand that when they have this feeling or when they have that urge, instead of releasing that urine in their clothing or in their bed, they are to go to the washroom. If these do not work, the next step is to receive medications such as desmopressin, imiprim, and oxybutynin. So desmopressin is pretty much an antidiuretic, and it is used to reduce the amount of urine in the body. So this helps to dry up the urine in the kidneys. So that means that this will cause the bladder to feel a lot less, so that when the child goes to bed at night, their bladder is not so full. It is relatively empty, and thus it will help to begin to create that dry bed that the child is and the parents are seeking. Secondly, imiprim, it helps also with the child to have that the dry bed. And basically it helps the bladder muscles to not necessarily, it relaxes the bladder muscles, but not to the point to where the bladder releases the urine. And finally, we have oxybutynin. This is an up and coming medication for enuresis. However, it is oftentimes prescribed along with the enuresis alarm. So if your child is not grasping the dry bed concept with the enuresis alarms, 9 times out of 10, the doctor will also prescribe some medications so that the child can begin to have the dry bed concept. It should be noted that these medications are not given to children in long-term dosages because there are some side effects that could be very detrimental to the child. So medications are often used in short term, so a month to 2 months, maybe at the max 3 months, because the goal is to train the child to gain continence and gain dry bed on their own rather than being medicated to do as such. And on this slide is my references for the presentation. I thank you for your time and have a great day. Bye-bye.